Good afternoon to everyone. And from Department of Medicine, Unit 3, we are presenting clinical background today. And the topic of the brand CGR is chronic pulmonary aspergillosis, clinical and research perspective from the last decade. We are going to discuss this CGR in the following headings: introduction, risk factors and epidemiology will be presented by Dr. Charu. Clinical features will be presented by Dr. Ved Prakash, he is Associate Professor in the Department of Medicine. Diagnostic radiology by Professor Surbhi Vyas. Diagnostic microbiology by Professor Gagandeep Singh. Treatment part, medical part will be presented by Dr. Anuj, and surgical part will be presented by Dr. Mohit Joshi. He is Additional Professor in the Department of Surgery. Then we'll discuss about the key points and conclusions. So I'll just invite you, Dr. Ramesh, to start this video.
Right. Thank you, sir. So, just briefly introducing the topic of chronic pulmonary aspergillosis. Most of the people here are from Department of Medicine. Also, other people are there. So, we all know this topic, but this was described for the first time almost 2 centuries back by this gentleman called Dr. John Hughes Bennett. So, he's a Scottish physician. He was, in fact, the same physician who first described leukemia. So you can understand there's a relationship between leukemia and aspergillus for a very long time. The radiological term of mycetoma was first described around 100 years back. So that was in France. Now it is important to realize that chronic pulmonary aspergillosis, or CPA, it is one of the most common manifestations of aspergillus-related lung disease, which kind of exists along a spectrum. So when I talk about this spectrum, so you can see this. So, invasive pulmonary aspergillosis, chronic pulmonary aspergillosis, as well as AVPA, there's a continuous spectrum. And depending on the immune status of the patient, so whether the patient is hypersensitive, immune competent, or immunosuppressed, so one of the conditions, EVPA, CPA, or IPA can result. So chronic pulmonary aspergillosis typically happens in patients who are immunocompetent. The second important concept is a radiological picture like this sufficient to diagnose chronic pulmonary aspergillosis? Well, the answer is no, because the diagnosis is not only radiological. It is, some people say it's a clinic radio immunomicrobiological criteria, which essentially means that you need a combination of symptoms, at least 3 months, plus radiological, plus immunological, and you have to rule out other causes before you can label a case as a case of chronic pulmonary aspergillosis. There are at least 4 or 5 subtypes which are as follows. So aspergilloma is usually what we see radiologically a fungal ball. CCPA is a cavity with symptoms and other features which can progress to CFPA. Chronic necrotizing pulmonary aspergillosis is a synonym for subacute invasive aspergillosis. So it does have a different trajectory. We are just going to touch upon SARA subsequently. And there is an aspergillus nodule, which is one of the only type of chronic pulmonary aspergillosis which does not have a cavity but a nodule per se. So I will hand over this presentation to my subsequent speakers, but I just wanted to tell you that during the presentation we are going to use these 2 icons. So AIIMS cohort, we are going to show a lot of published data from other centers as well as from our centers. So our center data, it would be indicated by this AIIMS cohort. And some of this work has been done in collaboration with our partners. So that is going to be indicated by this collaboration icon, right? So with this, I would like to invite Charu to take on the discussion.
Thank you, sir. So I will be starting with the risk factors and epidemiology of chronic pulmonary aspergillosis. So from this graph that I have taken from the Global Action Fund for Fungal Infections, we can see that India has one of the highest prevalence rates of CPA per 1 lakh population, which translates into the highest number of estimated 5-year CPA prevalence in the number of cases, signifying a truly high burden. So looking at the absolute numbers, the computation of the burden of CPA across the globe and in the Indian cohort was initially done in 2011, which was further updated in 2020, and this updation required some computational strategies or modeling exercises which were done, and which required a major contribution from our department as well. So, putting all of this in perspective, we know that pulmonary TB cases in India occur at a rate of around 2 million per year, which translate to around 0.4 million CPA cases, which is about 1/6 of this population per year, which is quite a significant burden. So then moving on to the risk factors of chronic pulmonary aspergillosis. So these can be extrinsic risk factors like underlying lung disease like post-tuberculosis lung disease, sarcoidosis, post-COPD patients, post-NTM patients, etc. As well as there can be intrinsic risk factors like immunogenetic makeup of the patient or microbiome, etc. So I will first be talking about the extrinsic risk factors. So the common denominator of all the lung diseases which predispose to CPA is lung cavities, which is cavitatory lung disease. And in a follow-up study of post-pulmonary TB patients, it was found that CPA occurs in cases with cavities around 6.5% per year compared to without cavities, which is 0.2%. So the difference in the rate is around 30 times. And other underlying diseases include post-COPD patients, post-NTM, as I have listed earlier, out of which, of course, the highest risk out of these is post-tuberculosis lung disease, followed by COPD patients, followed by post-NTM, and etc. So, what about other countries apart from India? So, we would traditionally believe that low to medium burden, TB burden countries might have risk factors other than post-TB lung disease. However, from this graph, which shows the Japanese cohort, as well as this graph, which shows the UK cohort, we can see that even in these countries, post-tuberculosis lung disease is the major risk factor. And of course, in our AIIMS cohort also, we found that post-TB lung disease was the significant risk factor. So since it is the most important and most common risk factor, I will be talking about this entity in greater detail. So tuberculosis is known to usually leave a scar on a majority of patients that it affects, and it can affect any part of the lung, including the airways, pulmonary vessels, pleura, as well as the parenchyma in the form of parenchyma destruction, fibrosis, cavitation, as well as aspergillus-related lung disease, which is the topic of our CGL. So traditionally, the pathogenesis of post-TB CPA was as follows. So in a patient who has tuberculous lung disease and develops cavities, these cavities subsequently get colonized by aspergillus during or after therapy, leading to chronic pulmonary aspergillosis after treatment. This was post-TB CPA. However, some new evidence has now shown that in a patient with TB lung disease, this aspergillus colonization can actually occur in concurrent to the start of TB therapy or even before that, leading to TB CPA coexistence. So this important fact was highlighted in a study done in Indonesia, which is the APICAL study. They assessed pulmonary TB patients at baseline and found surprisingly a 6% prevalence of CPA at baseline. So does this reflect a similar pattern in other high TB burden countries like India also? So the answer is yes, and this particular fact was proven by a study which was done from our cohort also, which showed similar results of a CPA prevalence of around 7% in newly diagnosed pulmonary TB patients. So how are TB and aspergillus actually related? So the short answer is that the relationship is manifold. So it can start with aspergillus colonizing a patient who already has TB disease in around 11 to 20% patients. Then there can be confusion between CPA and TB, especially in patients who have sputum negative TB, who can be actually misdiagnosed, and they are actually chronic pulmonary aspergillosis. Then in TB lung disease patients, aspergillus can be a co-traveler and exist as a coexisting infection in around 5%. Then of course the traditional belief that after tuberculosis is treated, then aspergillus colonizes the cavities and causes CPA as a post-TB sequelae. And also it has been shown that CPA has a compounding effect of increasing risk over the years. So after finishing with post-TB lung disease as a risk factor, moving on to post-COPD lung disease as a risk factor for CPA. So the data is quite limited. However, in various European cohort studies, it was found that the prevalence of CPA in post-COPD patients was around 9%, which was also shown to be similar in one of the Indian cohorts as well, which was around 9.8%. Then moving on to post-NTM lung disease patients. So again, the data is limited and majority of the literature comes from Japanese cohorts. And Southeast Asian studies, including Korean and Japanese studies, have put the prevalence rate between around 7 to 11%. And in a recent systematic review and meta-analysis from India, it was also shown that the prevalence was around 7% in post-NTM lung disease patients. So with this, we finish the extrinsic risk factors. And moving on to the intrinsic risk factors for CPA, this is an ongoing UK-India collaboration study which has studied the whole genome sequencing of CPA versus non-CPA patients, and it was found that there were significant differences in 8 single nucleotide polymorphisms found in CPA patients, and also there was a significant difference in the European cohort as well. And it was found from this Manhattan plot that 3 chromosomes, which is chromosome 4, 9, and 13, was found to be significantly linked with patients who further risk of CPA. And then there have been some studies done across the world determining the immunological profile of CPA patients. And there have been studies done on the qualitative and quantitative effects on lymphocytes in the peripheral blood of such patients. And also it was found that there was impaired interferon gamma production in CPA patients. So also we found that in our cohort, which constituted majority of the patients who were post-tuberculosis lung disease patients, we found that only a third of these patients had IGRA positivity. So this could have multiple implications, one of which is that maybe such patients never had tuberculosis to begin with. And another implication would be that these patients have a genetic defect of interferon gamma production, which might subsequently lead them to be at risk for further CPA infections. Then in another study in our cohort, which was done in collaboration with the Department of Biotechnology, we studied the flow cytometry of the peripheral blood of CPA patients versus controls. And it was found that in CPA patients, the population of B cells, cytotoxic T lymphocytes was higher, and TH helper cells population was low. So this might later on have a role in immunomodulatory therapy for CPA management. So lastly, coming on to an entity which is not traditionally considered as a risk factor for CPA. However, the study of microbiome of CPA patients versus non-CPA patients in our cohort yielded some very surprising results. So here we can see what we traditionally might believe would be that CPA versus non-CPA patients would have a different microbiome, with Aspergillus species predominating in the CPA population. However, we can see that this is mostly similar. The purple part here we can see is Aspergillus. It is mostly same. However, in patients of CPA with raised bag electromagnet, we could see that Aspergillus species predominate. And also another surprising result was that some other fungal species also predict the phenotypic behavior and the radiological changes of CPA patients, which could further have an implication in how we manage and how we predict the behavior of such patients. So summarizing my part, which is the epidemiology and risk factors, CPA has a significant global as well as Indian burden. Post-tuberculosis lung disease is the most common and the most important risk factor, along with other risk factors like COPD, post-NTM lung disease, etc. TB and Aspergillus have a manifold relation and complex relationship, and intrinsic risk factors like the immunogenetic makeup of the patient as well as the microbiome need to be kept into mind when dealing with such patients. So I would like to hand over to Dr. Ved sir for a discussion on the clinical features.
Thank you, Charu. Good afternoon, everybody. Chronic pulmonary aspergillosis is categorized into 5 subtypes: chronic cavitary pulmonary aspergillosis, chronic fibrosing pulmonary aspergillosis, simple aspergilloma, Aspergillus noodle, and subacute invasive pulmonary aspergillosis. Rather than being distinct subtypes, these are overlapping manifestations which can evolve in between over time. Chronic cavitary pulmonary aspergillosis is a most common manifestation of CPA. Untreated, it may progress to chronic fibrosing pulmonary aspergillosis. CCPA patients present with productive cough, hemoptysis, shortness of breath. They may also have constitutional symptoms like loss of appetite, loss of weight, and fatigue. CFPA patients present with worsening shortness of breath, chest tightness, weight loss, and they are more likely to be malnourished. Less common presentation of CPA include aspergilloma and Aspergillus noodle. Simple aspergilloma is a single fungal ball in a single cavity with no progression and fewer symptoms. Complex aspergilloma is now known as CCPA. Similar to aspergilloma, aspergillus nodule is also usually asymptomatic and is usually diagnosed on histopathology. On radiology, they can mimic lung carcinoma, metastasis, or cryptococcosis. All these manifestations are seen in non-immunocompromised patients with current or pure lung disease, except subacute invasive pulmonary aspergillosis, which is found in moderately immunocompromised patients. These immunocompromised conditions can include diabetes, older age, chronic alcoholism, radiation therapy, steroid use, and symptoms of subacute invasive aspergillosis is similar to CCPA, with more prominent continuous symptoms like fever. In a case series of 10 subacute invasive aspergillosis patients with recent history of COVID-19, which was published by our department, cough and hemoptysis was main presenting symptoms. 7 out of these 10 patients were having diabetes, and all of them had history of steroid use. In our AIIMS cohort also, CCPA was more frequent presentation, contributing to around 2/3 of patients of CPA. Aspergillus nodule and chronic fibrosing pulmonary aspergillosis constituted 14% of it, and simple aspergilloma was found in around 5% of patients. Chronic pulmonary aspergillosis is a frequent complication of treated pulmonary TB, and as we have seen, CPA has clinical manifestation similar to pulmonary TB. So, how to distinguish between CPA and reactivation of pulmonary TB in post-tuberculosis lung disease patients? Current literature says that fever and night sweats are more common in pulmonary TB patients, while persistent cough and significant hemoptysis is more commonly found in chronic pulmonary aspergillosis patients. Mild cough, fatigue, shortness of breath, and trivial hemoptysis can be found in both of them. In our AIIMS cohort patients, fever was present in both CPA and TB reactivation patients, although it was little more common in TB reactivation. Cough, hemoptysis, and shortness of breath was found more in chronic pulmonary aspergillosis patients than in pulmonary TB patients. Coming to allergic bronchopulmonary aspergillosis, till now recently, it was seen in mainly chronic fibrosis and asthma patients. But similar to chronic pulmonary aspergillosis, ABPA is also being linked to post-tuberculosis lung disease. In our patients also, out of 1,012 patients, ABPA was found in 2.3% patients, and aspergillus sensitization, which is defined as positive aspergillus specific IgE antibody, was found in 0.7% of patients, and chronic pulmonary aspergillosis was there in around 20.8% patients. So, how does aspergillus sensitization affect patients in CPA patients, and what is the clinical significance of aspergillus sensitization in these patients? In this study, CPA patients with aspergillus sensitization was having worse quality of life. These patients were having more number of fungal balls, and there was higher relapse rate after treatment discontinuation. Airflow obstruction was more common in CPA-AS patients compared to CPA-only patients. And these patients were having less relapse-free survival compared to CPA-only patients. In data also, shortness of breath was more common in ABPA with PTLD group patients, while hemoptysis, loss of weight, and loss of appetite was more common in chronic pulmonary aspergillosis and PTLD patients. Till now, we have seen the clinical difference between CPA and PTLD patients. But how does it translate to patient, and how does it affect patient's quality of life? Let's see. In this study, patient quality of life measured by SGRQ score was poorer in CPA PTLD patients compared to PTLD only patients. And out-of-pocket expenditure was more in CPA patients compared to PTLD only patients. Main contributor of this was hemoptysis, emergency hospitalization, and bronchial artery embolization. To summarize, clinical features may overlap between CPA, PTLD, TB reactivation, but some, including hemoptysis, may be more common in CPA. Aspergillus sensitization may occur in PTLD patients and CPA with possible impact on clinical outcomes. CPA can significantly impact patient quality of life and may incur higher financial burden on these patients. Thank you. Now I would like to invite Professor Sudhi for discussing radiology.
Good evening and thank you, Dr. Ved. So for radiology, it is the non-contrast CT, that is a high resolution CT or HRCT as we commonly say, which forms the mainstay of diagnostic protocol. Even though there is a significant overlap amongst the various subtypes and their radiological features, we have some key features which can help us in distinguishing one from the other. A simple aspergilloma is seen as a single cavity. This can be a pre-existing cavity with a soft tissue nodule within. The air which outlines the soft tissue is termed as the Monod sign or the air crescent sign. There can be an associated consolidation and fibrotic strands around the cavity. So this is a simple aspergilloma. Compare and contrast this with a CCPA in which there are more than two cavities. So there are multiple cavities. These are thick wall cavities with associated fibrosis and consolidation. And one or more of these cavities may show an aspergilloma. Now these are commonly seen in the post-tubercular lung disease patients. So they are bilateral, they can be asymmetrical in appearance. Now the patients of CCPA, depending on the immune status, may progress in the form of coalition of the cavities and can form chronic fibrosing pulmonary aspergillosis or the subacute invasive pulmonary aspergillosis. The latter is seen as an increased thickness of the cavity with a much larger area of consolidation associated with it. So these are the typical features of subacute invasive aspergillosis. On the other hand, CFPA is said to be there when there is two or more than two number of lung lobes are destroyed and show extensive fibrosis with evidence of volume loss and architectural distortion as we see in these images. Now these cavities which may coalesce to form a single large thick wall cavity may also show an aspergilloma as we can see here. The next is a simple aspergillus nodule. Now these nodules can be single or multiple, not associated with cavitary change. They are usually less than 3 centimeters in size. Sometimes larger nodules may show cavitation. The important thing to note is the absence of cavitary changes and absence of extensive consolidation associated with an aspergillus nodule. But we need to remember, in absence of other abnormalities, this needs to be differentiated from other causes of multiple lung nodules like metastasis, like Rasmussen aneurysms, and other infections like histoplasmosis. The use of contrast in CT in the form of CT bronchial angiography forms a roadmap for these patients are coming regularly with recurrent hemoptysis. So it forms a roadmap for an intervention to control the status for hemoptysis in the form of bronchial artery embolization. So the diagnostic algorithm of chronic pulmonary aspergillosis depends on the predominant finding, whether it's a nodule or it's a cavity. If it's a simple nodule, we know that it's an aspergillus nodule. If it's a cavity with intracavitary soft tissue, which if it is mobile is usually due to an aspergilloma. If it's a non-mobile intracavitary soft tissue, we consider the other differential diagnosis as I said earlier. If there are new cavities which progress slowly with paracavitary infiltrates and or fungal ball, then it is CCPA, which if left untreated may progress to chronic fibrosing pulmonary aspergillosis. If there is a rapid progression of clinical as well as radiological features, it may result in subacute invasive pulmonary aspergillosis, which may be even further complicated with presence of pleural thickening, empyema, and bronchopleural fistulas. Now, an important consideration in these patients is distinguishing the PTLD CPA with from recurrent pulmonary tuberculosis and this was the results of a study that was performed in our institute, where an AI model was used to diagnose CPA in patients with prior tuberculosis. Now, this AI model showed a very high specificity and a high negative predictive value to differentiate PTLD from recurrent pulmonary tuberculosis as well as from chronic pulmonary aspergillosis. Now, radiological characteristics to distinguish one from the other would also depend on the number of cavities. So, usually we find increased number of cavities. So, there are multiple cavities more commonly situated in the upper lobes, as well as the cavity size, the cavity thickness, and the pericavitary fibrotic changes. Now, these results are from a study which was done in PGI Chandigarh, where they evaluated 103 patients, and they found that even though the results were not statistically significant, they found that an increase in the cavity size and increased cavity wall thickness was seen in CCPA and CFPA compared with a simple aspergillosis. These are results from the AIIMS data to distinguish CPA-PTLD versus just PTLD. Here again, the presence of cavity, bronchiectasis, aspergilloma, and associated consolidation were distinguishing features between these three entities. This is the larger AIIMS cohort data, yet unpublished, which also showed the presence of cavity, which was present in 172 out of 243. So more than 70% of patients in CPA compared to 55 and 53 patients in PTLD and tubercular reactivation. Apart from that, presence of aspergilloma was seen in CPA, but no cavity with intracavitary soft tissue was seen in PTLD and TB reactivation patients. Another important indication for radiological evaluation is response assessment. Now, response assessment on radiology has been described as a decrease in the maximum pleural thickness, a decrease in the cavitary wall thickness, as well as a reduction in ground glass opacities, consolidation, and micronodules on semi-quantitative analysis with absence of new radiological features. Another entity that on radiology and nuclear medicine helps in response assessment has been evaluated in the recent past. So 77 patients with chronic pulmonary aspergillosis were studied in this case. This was a study published from PGI Chandigarh, where from 77 patients, 43 patients were deemed as treatment success and 34 were deemed as treatment failure. Multiple parameters were evaluated in FDG PET, and there was a good correlation or complete correlation between the ones which had a treatment success, whereas there were fairly good correlation, that is worsening in 21 clinically and worsening in 16 radiologically. So there was a fairly good correlation in the treatment failure group as well. So these are the various parameters seen between these two groups. So out of these, the SUV max and the mean SUV as well as the Z scores, these were the parameters most significantly associated to differentiate between these two entities. So to summarize, we can say that radiology plays an important role not only in diagnosing but also in classifying subtypes and in response assessment, apart from providing a roadmap for further invasive and partially invasive investigations like bronchial artery embolization and bronchial BA and CTBA. Specific radiological features include cavity, pleural thickening, fungal ball. These are more commonly seen in CPA as compared to the other differentials, which are the post-tubercular lung disease, reactivation of pulmonary tuberculosis, and ABPA PTLD. AI has a role in differentiating between these very similar entities and may have a role in future, as can be explored in again. PET and FDG PET may have a potential in response assessment, as we have seen in the few publications that have come up in the recent past. Thank you. With that, I give the podium to Professor Gagandeep to talk about the diagnostics part.
Thank you, Dr. Shruti. So I'll be talking about the microbiological diagnosis of CPA. And if you look at the evidence which we need to show is primarily by demonstrating Aspergillus specific IgG. Others like septate hyphae and growth from any respiratory sample, generally 2 or more, are considered appropriate evidence of Aspergillus in the respiratory tract. Initially, when the diagnostic algorithm was brought into practice, so mycobacterial infections had to be ruled out. But with experience, we know that both CPA and TB can coexist. However, the radiologically, as Dr. Subbi has indicated, there might be certain differences which may help us differentiate between the two entities. If you look at the investigations that can be done on respiratory specimens, so best are direct microscopy, which can demonstrate specific hyphae, fungal cultures, and histology. Although Aspergillus PCR, galactomannan are being done, however, their sensitivity and specificity, specifically for CPA, is not very not up to the mark. So this is what we do in the laboratory. So whenever the sample comes to us, so demonstrating septate hyphae with acute angle branching can be demonstrated on KOH calcoflow, and on culture, although this is one of our basic tools, however, as far as CPA is concerned, it has several limitations, it being a sort of a low load condition. So in various studies, the culture positivity has been shown anywhere between 11% to 80%. Therefore, and Aspergillus being ubiquitous, interpreting cultures in isolation is can be very, very difficult. In the AIIMS cohort, we've shown that the direct microscopy can be somewhere between 5 to 6%, and fungal cultures just double the number, or help in diagnosing CPA. Serology, is the mainstay in diagnosing CPA, and precipitating Aspergillus IgG antibodies have the best sensitivity of around 80 to 90%. There are other assays available like galactomannan can be used. However, again, the sensitivity specificity is not very good. For decades, we've been doing precipitants, but precipitants have one major limitation, that the specificity, although is very high, but the sensitivity is extremely low, maybe around 10 to 20%. So therefore, not a very valuable assay to be performed as far as CPA is concerned. Currently, the Thermo Fisher system FADIA, which is a fluorescent antibody assay, is being used throughout the world, and there are other assays also available with reasonable sensitivity and specificity. If you can see in this table below. So, another system by Biorad, Immunlight, all have reasonable sensitivity and specificity. But in India, basically, Immunocap is the one which is available. So we also had an opportunity to sort of evaluate this point of care lateral flow assay, which was brought into the market way back in 2018 and 19. And we compared it with the sort of current gold standard, which is Immunocap. And it showed reasonable specificity of around 83%. However, in both patients, with the prior history of TB or any lung cavity, the sensitivity was on the lower side. So, having low sensitivity, it cannot be used as a rule-out test. And in patients where there is high suspicion of CPA, they had to be negative tests had to be confirmed with an Immunocap. This is one study from PGI Chandigarh where they have shown that although our major focus over the years has been on Aspergillus fumigatus as a cause of CPA, however, so they looked into CPA due to Aspergillus flavus, Stirius, and Niger, and they showed that they might in their cohort it contributed to almost 25%. So we may be missing 1/4 of the cases of CPA if we are just looking at Aspergillus fumigatus. PCR, we've been doing PCR for quite some time, but as far as CPA is concerned and Aspergillus being ubiquitous, our experience hasn't been good. Aspergillus PCR in the blood may be able to differentiate, invasion from a simple colonization. And there's one of the Japanese studies where they had actually shown very promising results from PCR with very high sensitivity and specificity, but somehow our experience has not been very good. In the future, I think that if we can sort of quantitate the Aspergillus in the respiratory tract and correlate it with CPA, that might be helpful. And even if we can show RNA, and it might show active infection, which also may be useful in differentiating actively multiplying hyphae from just the ones which are colonizing. PCR can also be used to differentiate, drug-resistant forms. So where you have given the patient itraconazole or voriconazole and the patient is not responding, rather than patient just not achieving appropriate levels, there might be times where the Aspergillus may be drug-resistant. So this was one of the studies where we had done Aspergillus PCR and BAL in the CPA cohort, where we had shown that Aspergillus PCR, as I've said, did not have good sensitivity or specificity. Serum and BAL galactomannan, rather contrary to the finding that we had expected, showed opposite results. That the serum galactomannan had good sensitivity, although low, good specificity, although low sensitivity, and BAL galactomannan showed much lower specificity, because we generally would expect that CPA being limited to the lungs would the PCR would be able to, or the galactomannan would be able to pick up Aspergillus in the respiratory tract. So that wasn't the case, and this led us to think that what could be the reason for that. Maybe the BAL being sent to the laboratory is diluted, or what dilution is being sent, and this led to this study which was done, and where different volume instillates were checked. So for every patient, we took 5 samples. So initially, the first sample was where 40 ml was instilled and then aspirated, and a cumulative volume of 40 was added to each step, where the final volume of 40, 80, 120 and 160 were obtained from each patient, and finally 1 ml from each of these aspirates were mixed together, just to see whether mixing all the instillates would make any difference. And this is what we saw, that the 1 in 40 dilution and the mixture gave us the best diagnostic yield, and the cutoff that we determined was galactomannan index of 1 gave us reasonably reliable results in diagnosing CPA. Role of bronchoscopy in CPA patients. So if at all, as Dr. Subi had also mentioned the algorithm, so if at all the patient is, there is very high suspicion of CPA, but the patient is seronegative. So in those cases, BAL galactomannan might really contribute, and this is our data, where almost 20% of the seronegative patients, we could make a diagnosis of CPA based on the bronchoscopy results, although direct microscopy and culture contributed minimally. Also in patients who are CPA suspects, doing a bronchoscopy might be helpful in establishing alternative diagnosis, where in this one of our cohorts, almost 12% additional diagnosis we could make of either TB or other diagnosis. So just to summarize, serology, as we know, plays a key role in diagnosis. Direct microscopy and cultures have limited positivity rates. Biomarkers, although they are well established for invasive pulmonary aspergillosis, however, their role is limited for CPA, and bronchoscopy and BAL-based microbiological investigations are helpful in seronegative CPA cases, and also to rule out coexisting TB as well as establishing alternative diagnosis. So I hand over the podium now to Dr. Anuj to discuss the medical treatment.
Thank you, sir. So I'll be discussing the medical management of CPA. So other than the management of hemoptysis using bronchial artery embolization and use of tranexamic acid, and the role of surgery in specific settings, which will be discussed subsequently, antifungal therapy forms a cornerstone for medical management of CPA. Azoles are the only currently available oral options, of which preferred first line includes either itraconazole or voriconazole. There is now sufficient data to suggest that newer azoles might be non-inferior to traditional azoles. So if we compare azoles, overall efficacy is somewhere between 40 to 80%, although efficacy data is more limited for the newer azoles. In terms of toxicity, common side effects include hepatotoxicity, which is slightly more common with voriconazole and slightly less common with newer azoles. Other side effects include GI symptoms, cardiotoxicity in the form of QTC prolongation for most of the drugs except isavuconazole, which causes QTC depression, and side effects associated with specific drugs include visual abnormalities, CNS symptoms, skin-related adverse effects, which includes phototoxicity, and development of skin cancer in patients on long-term voriconazole.
and pseudohypoaldosteronism in patients who are on posaconazole. Although exact proportion of patients who develop this side effect is not clear, a single study had reported as high as 23% of patients reporting this. Since most of these drugs follow first order kinetics, one needs to obtain a trough level to ensure that patients have adequate drug levels. Now, is there a difference or choice amongst azoles? So this study had compared ITRA versus VORI in terms of initial maintenance therapy for CPA. What they noted was that clinical improvement was higher in the voriconazole arm. However, when they combined both patients who were stable or showed clinical improvement, there was no significant difference. Hospital readmission rates, however, were slightly higher in patients who started off with itraconazole as initial maintenance therapy. A subsequent systematic review network meta-analysis had compared various azoles in terms of their efficacy. As we can see, since most of these lines cross the line of no effect, there is no definite choice amongst azoles to start as initial maintenance therapy. So in patients who have either azole toxicity or develop or have azole resistance, and in pregnant patients, our options are more limited. So one has to resort to IV medication. So this includes either echinocandins or liposomal amphotericin B. Of echinocandins, most evidence is currently available for microfungin. In terms of efficacy, it is somewhat similar to azole. However, they have lower toxicity and less drug interactions. Between echinocandins, there is no significant difference in efficacy which has been noted. People have also tried pulse echinocandin therapy with a duration of around 2 weeks repeated every 1 or 2 monthly and had shown similar mortalities and pulmonary functions as compared to traditional azoles. The other option is liposomal amphotericin B. However, it shows no efficacy benefit and has significantly higher toxicities. So this was one of the larger cohorts which had evaluated liposomal amphotericin B in patients with CPA from UK. So they had shown response rates of around 70%. This is a summary of available evidence for IV therapy. So if we see the pooled estimates, in terms of efficacy for echinocandins and amphotericin, it's around 60%. There is no, but echinocandins are associated with less toxicity. So most of this discussion revolves around patients who have chronic progressive forms like CCPA or CFPA. But in patients who have, say, simple aspergilloma or aspergillus nodule, the role of antifungal therapy is more limited. All patients do not require antifungal therapy. So the role may be limited to patients who are immunocompromised or have radiological progression or might be at risk of post-operative aspergillosis. For example, if the aspergilloma is close to the pleural cavity, in patients with relapse, and in cases of aspergillus nodule, possibly in terms of in cases with multiple nodules or progressive disease. So now I have discussed oral and IV options, but can we give antifungal therapy through other routes? So we had evaluated in a cohort of 32 patients whether nebulized amphotericin B shows any benefits. So it was compared to oral itraconazole in patients with aspergilloma and had shown non-inferiority. Only major adverse effect was minor cough. However, it did not require treatment discontinuation. On the right is an ongoing study from the department, which is a placebo-controlled, double-blinded, multi-center RCT, which is evaluating the role of nebulized amphotericin B added to oral itraconazoles in patients with CPA. So this is from our institute only. So this was another modality which was tried, that is intrabronchial triazole therapy. So they had given voriconazole for 400 milligram every weekly for 4 doses and had shown that severity of hemoptysis and percentage of patients who show clinical improvement as well as size of aspergilloma had shown significant reductions in patients who received intrabronchial triazole therapy. People have also tried intracavitary amphotericin B in patients in non-surgical aspergillomas with antifungal treatment failure. However, the complication rates with this is quite high. So as discussed previously, these patients might have interferon gamma deficiency. So in this retrospective cohort from UK, they had evaluated whether interferon gamma replacement offers some benefit. What they had shown was patients who receive at least 12 months of interferon gamma might have lesser exacerbations and hospital admissions in the duration when they received this as compared to pre-interferon gamma initiation. So based on this, an ongoing trial is recruiting patients evaluating the role of interferon gamma immunotherapy in patients with CPA. So now that we have discussed various agents of therapy, modes of therapy, how long do we give treatment? For oral azole therapy, most guidelines used to recommend at least 6 months of therapy till this paper was published in 2022, which evaluated 6 months versus 12 months of therapy and had shown that overall outcomes, clinical response, and radiological response was better with 12 months of therapy as compared to 6 months. There is some retrospective data to suggest that patients with more extensive disease might benefit with treatment beyond 12 months. Now coming to treatment response assessment, it has three components: clinical, which should be objective, usually based on a visual analog scale, with a percentage change of more than 25% being considered significant. Radiological, which ma'am has already discussed. Microbiological is more difficult because of poor sensitivity and specificity of cultures. Role of serology is not defined because a significant proportion of patients might remain serology positive even after long duration of treatment. Now, what are some of the therapeutic challenges one faces while treating these patients? First would be relapse. So, in the paper which I discussed, relapse rates were quite high. Relapse rates with 6 months of treatment was around 38%, and even with 12 months, there were around 10% of patients who had relapses. So, what are the risk factors for relapse? Strongest risk factor is the extent of the disease, so bilateral lobe involvement and duration of therapy. In patients who are treated and do not show response, so it should trigger evaluation on three fronts. One is inadequate drug levels, possible azole resistance, and co-infections. So starting off with azole resistance, although data from Europe suggests that primary azole resistance might be as high as 40 to 50%. So we had evaluated azole resistance in Asian isolates, and we're able to show that our primary azole resistance rates might be less than 10%. Second would be inadequate drug levels. Literature says that up to 40 to 50% patients might not achieve therapeutic drug levels, either due to differences in formulations or possible drug interactions. Finally, co-infections. So as discussed previously, NTM and TB can precede, coincide, or follow CPA. In addition, bacterial co-infections can also be present in around 1/5 of the patients, thereby affecting clinical outcomes. So this was a systematic review, IPD meta-analysis, which was done from our department in collaboration with 13 other centers, evaluating 79 studies and around 9,000 patients. So overall 5-year mortality was as high as 32%, with first-year mortality of around 15%. Amongst risk factors, what was noticed was age was a significant risk factor, with increased risk with every decade. CPA subtype, for example, is subacute invasive aspergillosis and CCPA as compared to aspergilloma was at a higher risk. And finally, what was interesting was patients who developed CPA in the background of tuberculosis had less mortality as compared to some of the risk factors described from the West. So to summarize, azoles are the first line of therapy and the only oral options available. However, there is no definite choice amongst azoles. Duration at least 12 months is ideal. However, a subset of patients might benefit from duration beyond 12 months. In terms of response, assessment should be based on clinical, radiological, and microbiological criteria. Even with treatment, mortality rates are high, with 1 in 3 patients not surviving beyond 5 years. So now I would like to invite Dr. Mohit Joshi sir for surgical management of CP.
Thank you, Dr. Anuj. So I'll just take you through a short journey of surgery for aspergilloma. So the surgery is definitive. What we do in surgery is we remove the disease part of the lung, and depending on what part is removed, maybe less than a lobe, when we call it sublobar section, or we sacrifice the whole of the lobe, lobectomy. At times when it's extending to the other part of the lung with the other lobe, we do bilobectomy and luminate. And this extent of resection depends on the underlying pathology. So what's the extent of involvement by aspergilloma and what is the condition of the underlying lung? Not all the patients are suitable for this. The patient will be fit enough to undergo surgery. So we have this assessment by having a global assessment of general condition and whether they have any comorbidities and whether they are optimized or not. And definitely we should kind of think that whether the patient has to breathe from the residual lungs, whether he is like fit enough to undergo surgery, whether he will be have ventilation with the residual lung. So these type of patients where the disease is limited to one particular lobe and the underlying lung is normal, they are suitable for surgery. So we can just say maybe the part of lobe or the whole lobe or 2 lobes or maybe the whole lung. But if these kind of patients where the disease is not limited to one side, but it is more extensive, now they are not suitable for surgery. So the suitable patient for surgery are the one with localized disease, or even if the disease extends to more than one lobe, they have good general condition and they have optimum pulmonary reserves. Now, how to have that kind of wisdom or understanding when the patient is having sufficient pulmonary reserves and he will be able to ventilate even after surgery is that we have this kind of assessment. So there's again a global assessment, what are the physiological parameters of the patient, and then we subject it to spirometry. Depending on the result of the spirometry, in an algorithmic fashion, we ask for simple exercise testing, and if like it is kind of equivocal, then we go for more complex tests. Now, surgery in chest is a different ballgame altogether. It's not like kind of abdominal where you make an incision, retract it, and then have a surgical space inside. The chest wall is rigid. So even if we make an incision and spread the ribs, the lung is inflated and we don't have sufficient space inside to work on. So to create space, we deflate that side of lung. So this has to be achieved as something called as one-line ventilation, and this tube, it helps in that. So it's like a tube in tube where one lumen remains in the trachea, the other lumen goes in the bronchus, and by selectively clamping one to the other end of it, we achieve like selective ventilation of one of the other. So this is how, when the lung is kind of deflated, we can create some space in the chest wall there and we can work. This is how the patient goes on the routine table, so it's kind of a dead lateral position. And we have approach of open surgery where we can incision, it's called a traditional thoracotomy, or else it may be by small incisions, like minimal access surgery, where we call it video assisted thoracic surgery. This is how it looks like in case of open thoracotomy. It's a big incision. We put in a chest wall tract and we can go inside, deflate the create space and work on. While in case of VATS, we make small incisions, the camera port goes inside, working port goes inside, and then deflation definitely is required, but this is achievable. Now, once we are inside, and depending on the extent of involvement of the lung, as I said, that we can do a sublobar resection. Here in the right side, you can see the specimen of a sublobar resection, or the whole lobe can be removed, or it may be more than a lobe, or maybe whole lobe. So the fungal volume cavity in CT, which you can see like this in a surgical specimen, looks like this. So here also you can see that. So this is the cavity, and this loose thing here is the fungal volume. It's not as simple as it seems. It's not that we go inside, we chop off that part and we come out. There are problems because it's a chronic inflammatory condition. The chest wall may be like the lung may be adhered to the chest wall. We don't get any space, even though the lung is deflated. It is stick to the chest wall. We work very close to heart and large blood vessels, so bleeding is a problem. There may be anatomical aberrations, and the fish may be fused, maybe congenitally, maybe because of inflammation. And then we lose an orientation, whether it's in upper lobe or middle lobe or lower lobe. It's very, very possible. I'll just show you some images. So this is how lesions look like. At times you cannot differentiate between the lobes. Or else, like you may have bleeding. So we were doing sublobar resection, and this is what we see. Now this is one thing which is kind of periphery, and then you can control it. But at times it will just go boom, and everything is kind of smeared there. So in the last 5 years, we have done close to 330 patients of hemoptysis only. And we can see here the fungal diseases, it forms the bulk of the surgeries. It's almost kind of 50%, and that's still on top of the list. So this is all from the surgery side. Thank you so much for the patience.
Right. So we are almost at the end of our presentation. So, the job at hand for me would be to just present the key takeaways from our clinical experience and our research experience from our department. So, if I can sum it up, tuberculosis is a much common disease, but for every 7 cases of tuberculosis, 6 cases of tuberculosis, 1 case of CPA will be there. So, CPA is actually a common disease that we encounter. We need a comprehensive clinical radio microbiological input. And we believe that bronchoscopy is a useful modality for ruling out or ruling in chronic pulmonary aspergillosis. As far as BAL GM is concerned, it has been kind of practice changing for us. We always send the BAL GM from the first aliquot. BAL PCR is not a useful modality for us, so we are not using it. POCT, in resource constrained settings, it may be good enough, but not really in our scenario where we already have immunocap. And despite treatment, 1 out of 3 patients die within 5 years of diagnosis. So evidently we need to do more work as far as the treatment is concerned. As Dr. Joshi said, surgical treatment is very effective in select cases, but the need of the day is optimal medical treatment strategy, which is kind of evolving. So this is the kind of the publication list over the last 10 years. So this is as you can see, mostly it's from clinical and diagnostic perspective, but also a little bit from management. But clearly we need more work to understand different aspects of this very enigmatic, such a common disease. But the work, which you have presented would have not have been possible without the help of different departments, the funding agencies, and collaborators. So, I take this opportunity to thank each one of them. So, with this, I would like to invite Sanatha for his concluding remarks.
I'm not going in detail due to paucity of time. Just we have already covered in detail regarding the CPA, and we have covered about the risk factors, clinical features, diagnosis, both radiology and microbiology, treatment part, including medical and surgical part, and key points. So I would like to thank all the speakers, and I would also like to thank to the audience for coming here. And we would like to have some questions and comments. Thank you.
In clinical decision making, how much of emphasis do you lay on seeing the electron, considering especially that it's very likely that false positive results may come out?
Right. So, thank you for the question. So, serum melatonin is actually not a good modality of it's supposed to be much better for invasive parameters. So, for either diagnosis or response to people using serum melatonin, or even the guidelines say that it should not. I mean, even in invasive parameters, what we notice is our dietary we are well published. It is influenced by a number of factors: food of the patient, drugs, and so on and so forth. So for us, even galectin is not really able to.
What would be the complete cure rate?
Thank you for the question. So, complete cure rate would be reported as less than 20%. Why? Because taking on 5% of our patients probably become treatment. And say another 10 to 15% of our patients will be able to stop the therapy and monitor them for 2 years and say that their living is not progressing. But the vast majority of the patients they kind of have relapsed issues. So it's a chronic disease. So the cure rate is in our cohort is not really high.
So basically, this is not a question, it's a comment merged with a question. First thing, I think it's a relatively newer disease, like you've already shown. Just maybe about 10, 15 years back, most of those fibrotic destroyed lungs that we used to classify probably today would be classified, many of them would be classified as CPA because of the diagnostic criteria that we have. So we have got a name of a disease now, that is one. Secondly, like you rightly mentioned, and I think the question was there, the challenge is in treatment. Diagnostics are quite clear. We have radiology, clinical aspects, but we are only as old as the treatment, and long-term follow-up, unfortunately, has not yielded good results. So the cure rate 20, 30, 40% at best, and they are shorter-term studies. We don't have long-term follow-up. It is like chronic progressive disease, like a progressive fibrosing ILD in a way. So that is the challenge as of now. Regarding prognosis, I had one question. Basically, do we have any prognostic things? You showed a couple of prognostic things, but we did a small bit of work, about 60 patients paper under review. We found that we can classify these patients also as Th2 high, Th2 low, just like asthma. So we found Th2 high, that is high absolute eosinophil count, has a better prognosis. That is what we found, small study. But I'm sure a lot of work will now happen towards the prognostics and phenotyping of CPA. So what in your experience are the prognostic markers? Are there any?
So one is some clinical features that, for example, we have done that mortality study. What we have noticed is
One is very intuitive, the age of the patient. So, either prevention, that is fine. There's some types of chronic pulmonary aspergillosis. For example, CFA or reverse prognosis. So that is the the kind of the macroscopical feature that can predict the prognosis in terms of mortality, or in terms of relapse also, the extent of disease, etc. There are some people, I've gone through the very interesting publication on H2. So there is also some data from PGI which shows that the VAL levels of the different interleukins, etc. We can also give. I think the evidence regarding this is still important. So, yes, we'll be able to measure the extent of lung involvement in terms of volumetric something that has a prognostic significance, because some part is post-productive. There may be a component related to that itself, which may be let's say contributing to the outcomes. But in addition, if you have this, would there be a way to quantify that extent of involvement and look at its contribution to the overall outcomes? Okay. Would be able to answer, but in the CPNN criteria, they have enumerated certain radiological criteria. That you see the cavity and you see the size of the cavity, the size of the fungal wall and the thickness, and also you see the pleural technique. So these are actually, we are doing that as part of a randomized control trial. We are seeing it objectively and over time, and we are trying to objectively report the results. After that.
So apart from the cavity size and the cavity thickness, one way of analyzing it would be to see a percentage of lung involvement. So there are various platforms. Some of them are freely available with the machines that we have, and some are more platform based, in which we can calculate on imaging the percentage of lung which is involved. So we can see how much of it is fibrous, how much of it has cavity involvement. So yes, that can be done and can be something that we can look at in the future.
Thank you. Dr. Umar?
So what's the way forward?
Right. So I think, what I would like to believe is that more focus on the actual problems that the patients have. We still don't understand why some patients are dying, not responding. I think more amount of research, more amount of diligent clinical follow-up, at least for me, I think would be the way.
Therapeutic drug monitoring also has a role to manage.
Yes, absolutely. So we are doing therapeutic drug monitoring. We wanted to show a slide on that, but a lot of our patients, we computed that 50-55% they are having low TDM, but probably we feel that it is due to the fact that we are not able to do the TDM at the right time. Patients are supposed to come before taking the the morning dose. They are reporting to us in the evening in the chest clinic. So I think there are some logistical challenges which is leading to that. But we are really doing TDM, and we want to also streamline it so that we can. No question from the residents. Okay, so there are no questions. Thank you.